Hey everyone, welcome back to all my listeners. This is episode 8 in season 18. Today is Wednesday, July 22nd, 2026. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Well, all right, you guys, welcome to another episode in the hot month of July. It's definitely hot where I am. We have been encountering a lot of dangerous, hazardous air quality here in the Midwest, especially from those wildfires in Canada that have been blowing down really crazy levels of smoke over the past week or so. So a lot of people with pre-existing lung conditions, asthma, etc., have really had a hard time breathing in the air here in this region. So definitely hazardous, definitely mask worthy when people need to go out and about, get groceries, fill up their gas tanks, etc. So really hitting a rough spot here, and definitely that drought condition is definitely here as well. We've not seen rain for many a day. Like I hinted at in a couple episodes before, that the month of June was really, really great for rain, but now here we are in the month of July. We haven't seen rain for a minute, and there's none in the forecast for the next 10 days. So we are in a drought-like situation here in the Midwest. So I hope everybody out there is staying safe. All right, you guys. Well, today's episode is just going to focus on one item, and it's a very important item. And I just wanted to highlight the Medicare physician fee schedule proposed rule for calendar year 2027. Now, the proposed rule is always a water cooler conversation piece year after year, in my opinion. So CMS has published a fact sheet last week regarding the calendar year 2027 Medicare physician fee schedule proposed rule. So I just wanted to read some highlights from the fact sheet that are important to not only my audience, but to the clients I serve. Quote, on July 14th, 2026, the Centers for Medicare and Medicaid Services, CMS, issued a proposed rule that announces and solicits public comments on proposed policy changes for Medicare payments under the Physician Fee Schedule, the PFS, and other Medicare Part B issues effective on or after January 1st, 2027. The calendar year 2027 PFS proposed rule is one of several proposed rules that reflect a broader administration-wide strategy to create a healthcare system that results in better quality, efficiency, empowerment, and innovation for all Medicare beneficiaries. Now, the fact sheet goes on and talks about the background on the physician fee schedule. Since 1992, Medicare payment has been made under the PFS for the services of physicians and other billing professionals in a variety of settings. For most services furnished in a physician's office, Medicare pays physicians and other professionals at a single rate based on the full range of resources involved in furnishing the service. In contrast, PFS rates paid to physicians and other billing practitioners in facility settings such as a hospital, outpatient department, or ambulatory surgical center reflect only the portions of the resources typically incurred by the practitioner while furnishing the service. For many diagnostic tests and a limited number of other services under the PFS, separate payments may be made for the professional and technical components of services. The technical component is frequently billed by suppliers for which no institutional payment is made, like independent diagnostic testing facilities and radiation treatment centers, while the professional component is billed by the physician or practitioner. Payments are based on the relative resources typically used to furnish the service. Relative value units, or RVUs, are applied to each service for work, practice expense, and malpractice expense. These RVUs become payment rates through the application of a conversion factor. Geographic adjusters, geographic practice cost indices, are also applied to the total RVUs to account for variation in costs by geographic area. Payment rates are calculated to include an overall payment update specified by statute. Now, the fact sheet goes on and talks about specifically the calendar year 2027 PFS rate setting and conversion factor. So this is where a lot of math goes into play, right? And as we heard, it's a lot of specific geographic information that is going to vary from state to state. Now it says, quote, as required by statute, beginning in calendar year 2026, there are two separate conversion factors. One, for qualifying alternative payment model, the APM participants or QPs, and one for physicians and practitioners who are not QPs. By statute, QPs are those that meet certain thresholds for participation in an advanced APM, which means generally that the payment model has features to ensure accountability for quality and cost of care. The update to the qualifying APM conversion factor for calendar year 2027 is 0.75% increase, while the update to the non-qualifying APM conversion factor for calendar year 2027 is a positive 0.25%. Now, the changes to the PFS conversion factors for calendar year 2027 include these updates as required by statute and an estimated plus 0.53% adjustment necessary to account for proposed changes in work RVUs for some services. However, Public Law 119-21, which CMS refers to as the Working Families Tax Cut, or WFTC legislation, provided a one-year PFS conversion factor increase of 2.50% for calendar year 2026, which will no longer be in effect for calendar year 2027. This effectively means that current law requires a negative 2.50% reduction in Medicare payment under the PFS compared to calendar year 2026. The proposed calendar year 2027 qualifying APM conversion factor of $33.17 represents a projected decrease of 40 cents from the current conversion factor of $33.57. The non-qualifying APM conversion factor of $32.84 represents a projected decrease of 56 cents from the current conversion factor of $33.40. Now, moving on, the fact sheet goes over accounting for overlap between standalone E&M visits and global periods. For calendar year 2027, we are proposing to reduce payment when a separately identifiable office and outpatient evaluation and management E&M visit is furnished by the same physician or a physician in the same practice on the same day as a 0, 10, or 90-day global procedure. The most expensive service, either surgical or E&M visit, would be paid at 100%, and all other surgical procedures or E&M visits furnished on the same day would be paid at 50%. This proposed policy is like a proposal in calendar year 2019 PFS proposed rule made in the context of a broader proposal that would have modified the payment structure of E&M visits. While CMS did not finalize the proposal at the time, CMS noted that they continued to believe that there are efficiencies when the same physician or a physician in the same group practice provides an E&M service for the same patient in conjunction with the procedure with a global period, and that CMS is likely duplicating payment under the current payment methodology. The current proposal would address that overvaluation. Now, the fact sheet moves on and talks about the E&M visit complexity add-on, or HCPCS code G2211. In calendar year 2021 PFS final rule, CMS finalized separate payment for the office or outpatient evaluation and management visit complexity add-on code with the HCPCS code G2211. Now, policy implementation was temporarily delayed by statute, but then implemented for calendar year 2025. Now, for calendar year 2027, CMS is proposing two changes. They are proposing to transition HCPCS code G2211 to a modifier that can be appended to the associated E&M base code, which is that placeholder modifier MOD1 will be placed with a 2-digit HCPCS modifier if finalized. Now, this modifier would increase the payment of the associated E&M code by 16% instead of a flat rate, maintaining an equal percentage increase across all levels of E&M codes. Now, CMS is also proposing to recognize additional resource costs incurred by practitioners in accountable care organizations, or ACOs, when providing longitudinal care, such as maintaining total cost of care accountability and reporting quality measures that can align with providing longitudinal care and care coordination. This modifier, with the placeholder modifier of MOD2, would be available only for practitioners participating in a shared savings program, ACO, or participant providers in a long-term enhanced ACO design model, ACO, and would increase payment of the associated E&M visit by 32%. Now, under this shared savings program, use of the MOD2 modifier would be voluntary and available to be billed for all beneficiaries to whom an ACO participant or provider furnishes services, not limited only to shared savings program assigned beneficiaries. The MOD2 modifier would also be voluntary for the LEAD model and could be billed for all beneficiaries to whom the participant provider furnishes services, not limited only to LEAD aligned beneficiaries. Claims submitted with the MOD2 modifier would be included in beneficiary assignment calculations, historical benchmark expenditures, and performance year expenditures for the shared savings program. Now, moving on, the fact sheet discusses remote monitoring. Recently, CMS has established payment for 2 code families that describe certain remote monitoring services. Number 1, remote physiologic monitoring, RPM, and remote therapy monitoring, or RTM. Now, for calendar year 2027, CMS is proposing to require that RTM services be furnished only to established patients, that practitioners reporting RPM or RTM services must furnish a separately reportable initiating visit in association with the onset of RPM or RTM services, and only to allow payment for RPM or RTM services when performed by clinical staff employed by the practice and not when those services are delivered by contractors. CMS is also proposing updates to how these services are valued under the PFS, as CMS understands that devices may be available at a reduced cost compared to their initial estimates. Now, CMS also considered, and they're seeking comments on, bundling the RPM and RTM CPT codes and creating 4 new HCPCS G codes to describe remote monitoring services. This approach would address recommendations from recent OIG reports that CMS does not believe can be fully resolved with the current coding structure of the remote monitoring code family. Now, they also move on and talk about practice expense. CMS has historically relied on the American Medical Association, the AMA, surveys to estimate physician work, direct practice expense inputs or PE inputs, and overall PE for calculating payment rates. Now, these recommendations have been limited by several factors, especially from a reliance on resource-intensive but ultimately unreliable surveys with low response rates asking for expert estimates that present significant discrepancies with alternative empirical data sources in the cases where empirical data exists. Now, these dynamics are particularly problematic for specialty-level practice expense data. In these cases, data collection is particularly burdensome and subject to volatility based on low response rates and significant incongruities in collection methodologies between physician groups and other entities paid under the PFS. CMS is engaged in a multi-year effort to transition the PE methodology away from reliance on the AMA's data and towards an approach that relies on more objective, routinely updated, and auditable cost data. Now, CMS believes this change will lead to PFS payments being more sensitive to market pressures, open broader possibilities for right-sizing payments across outpatient care settings, and make payments more transparent for practitioners and beneficiaries. As part of reforming the way PE RVUs are assigned to specific services, CMS is proposing to reduce reliance on outdated specialty-specific practice expense per hour, or PE over HR data. Now, specifically, CMS is proposing a phase-out part of the methodology that ensures the overall number of PE-RVUs by specialty is consistent with the old PE over HR data from 2007 or earlier. Now, under the proposed methodology, the final PE-RVUs would still be derived from the input data, which means including both the work RVUs and direct PE inputs, as well as specialty-specific indirect allocators. However, the existing final step would be phased out over several years and replaced with a PE stabilizer that mitigates short-term volatility without anchoring overall values to a specific point in time. Based on feedback from interested parties, CMS is also proposing to adjust the indirect PE allocation for visits furnished to beneficiaries in a Part A stay in a skilled nursing facility or SNF, consistent with their site of service payment differential policy finalized in the calendar year 2026 PFS final rule. Now, CMS is also seeking comments on whether the site of service payment differential between facility and non-facility is still appropriate, or whether CMS should consider an alternative approach to improving assumptions about indirect practice costs, particularly for physicians employed by a hospital, health system, or other entity. Now, the fact sheet moves on and talks about comment solicitation on strategies for improving global surgery payment accuracy. Now, for calendar year 2027, as part of an iterative process to improve global surgical service valuation and payment accuracy, CMS is proposing to pause the data collection required by Section 523 of the Medicare Access and CHIP Reauthorization Act, or MACRA. Now, CMS can continue to assess how best to use the data and what CMS can do to improve this data collection going forward. CMS currently has several years of data showing that post-operative visits during the global period are not occurring, yet providers are still being paid for these visits under the current global payment policy. Additionally, CMS believes that current data collection requirements may be causing undue burden to providers, and that pausing the data collection will help reduce the burden for practitioners. CMS is soliciting public comments on expanding their data collection as well as other data sources that they might consider to more accurately value payments for global surgical services. Additionally, CMS is posting a public use file with this proposed rule to display the inputted RVUs associated with both the 10 and 90-day postoperative visits based on a purely arithmetic approach to understand the valuation of the services based on the analyzed data. CMS also welcomes comments on potential reevaluation strategies that they may consider through future rulemaking. Moving on, the fact sheet talks about policies to improve care for chronic illness and behavioral health needs. 3 in 4 American adults have at least one chronic condition, and more than half have 2 or more chronic conditions. CMS is directing focus toward understanding and drastically lowering chronic disease rates, including thinking on nutrition, physical activity, healthy lifestyles, over-reliance on medication and treatments, and the effects of new technological developments. As such, focusing on the prevention and management of chronic disease is a top priority for CMS. In calendar year 2026, CMS broadly solicited feedback to help them better understand how they could enhance their support of the prevention and management of chronic diseases. Based on commenters' feedback, CMS recognizes the importance of healthcare delivery approaches that enable multidisciplinary support, foster patient engagement, and encourage sustainable lifestyle and behavioral changes. Shared medical appointments are one such approach to offer a group-based environment in which patients can receive clinical guidance while also engaging in peers facing similar health challenges. Shared medical appointments may also help address social isolation and loneliness for some beneficiaries. Currently, no HCPCS code specifically describes shared medical appointments. Therefore, for calendar year 2027, CMS is proposing to establish separate coding and payment for shared medical appointments. Behavioral health conditions are some of the most common chronic health conditions nationwide. Even patients with physical chronic health conditions frequently experience related behavioral health concerns and achieve better management and improvement of their physical chronic conditions when these behavioral health concerns are also addressed. In the calendar year 2024 PFS final rule, CMS finalized an increase in the valuation for timed behavioral health services by applying an upward adjustment to the work RVUs for psychotherapy codes payable under the PFS. This increase is being implemented over a 4-year transition period. CMS believes similar adjustments are warranted for smoking and tobacco use cessation and screening, brief intervention, and referral to treatment, or SBIRT services. Therefore, for calendar year 2027, CMS is proposing to include smoking and tobacco use cessation services and SBIRT services in this final year of the transition for timed behavioral health codes. Now, the CMS fact sheet includes more information. The CMS proposed rule document encompasses 1,592 PDF pages, and the published version in the Federal Register includes a PDF of 716 pages that outline the steps needed to include your public comments by September 14th, 2026. So please make sure and take the time to review either version to understand all the proposals that are being made. There are also 6 additional ABA types of codes that may take effect as of the final proposal that will be coming out after September 14th. So stay tuned for those 6 code updates as well in a future episode. Now, one specific additional item that I want to highlight includes public comments wanted for why we use CPT and what changes could be made on PDF pages 304 through 308 of the 1,592 page CMS proposed rule. And it states, quote, "New CPT codes are introduced by the CPT Advisory Committee. This committee was established following the initial publication of the CPT coding system in 1966, which provides advice on procedure coding and appropriate nomenclature as relevant to the committee members' specialty and consists of members of national medical specialty societies seated in the AMA House of Delegates. When a new CPT code is defined by the CPT Advisory Committee, it is then assigned a payment value by the AMA Relative Value Scale Update Committee, or RUC. The AMA RUC was established in 1992 after CMS transitioned to the Resource-Based Relative Value Scale, or the RBRVS, to provide recommendations on the valuation of physician services. As established in Section 1848 of the Social Security Act, CMS began paying for physician services in 1998 on the basis of a product of the relative value of the physician service, incorporating the physician work, the practice expense, and the malpractice component. These elements form the basis of the RBRVS. The components of physician services were originally established by a team of Harvard researchers, and CMS has occasionally referenced the Harvard valuations, making reference to these original contributions. According to the AMA RUC, quote, "provides medicine a voice in shaping Medicare relative values," end quote. And by all published estimates, this has been an effective mechanism. There has also been longstanding concern expressed over the federal reliance on a private organization with such an obvious conflict of interest as providing information on the time and resource requirements to conduct physician services when this information may influence their own payment. For nearly 20 years, MedPAC has expressed concern over the influence of the AMA RUC to value services, specifically noting that CMS has, quote, "over-relied on specialty societies with a financial stake in the process," end quote, and has recommended that CMS establish a separate group of experts to make payment recommendations. Further, CMS notes the development of U.S. healthcare as a sick care system with limited emphasis on prevention and lifestyle modifications, and which may inhibit progress on the secretarial priority to make America healthy again. Additionally, CMS notes a recent National Academies of Sciences, Engineering, and Medicine, or NASEM, report recommending RUC alternatives for establishing primary care payment, valuation, and recommendations for alternative sources for data collection. Given these long-standing concerns, CMS is seeking comment on a number of areas regarding the influence of the CPT coding system and AMA process on physician payment policy as part of the secretarial priority to make America healthy again. Number one, what, if any, evidence is there for CMS to consider regarding the harms or challenges associated with AMA's monopoly over CPT-4 licenses for healthcare entities? Please cite potential improvements to patient care diverted or delayed due to AMA's monopoly over CPT codes, including inhibited innovations and acquisition or maintenance costs of CPT licensure. Number two, what, if any, evidence is there that the generation of CPT-4 codes follows a process of identification of medical necessity? What opportunities or examples from other populations, sites of care, or international health systems could instruct a process of identification of medical necessity in the CPT-4 code development process? Number three, a combination of CPT-4 and HCPCS codes were formally adopted by HHS as the legal standard for national coding for physician and other services as part of implementing HIPAA under 45 CFR 162.1002A5. If CMS were to revisit this standard in future rulemaking, which, if any, alternatives exist to CPT-4 for CMS to consider as part of the national coding standard for physician services? Would CMS need to specify a separate legal standard, or could CMS allow for private competition to supplement the existing CPT-4 coding standard? And number four, what objective alternatives exist or could be developed to maintain a more objective process to the current AMA, CPT, and RUC committee processes? How would these alternatives support or inhibit innovation? Number five, what are the benefits and drawbacks of paying for physician procedural services on the basis of the underlying International Classification of Diseases, 10th revision, or ICD-10 procedure codes, as an alternative to CPT-4 code? How could the International Classification of Diseases 10th revision procedure coding system, or ICD-10 PCS, services be grouped or bundled into payment categories similar to Medicare severity diagnosis-related groups, or MSDRGs, or outpatient prospective payment system, OPPS, ambulatory payment classifications, APCs? What other alternatives exist for bundling or grouping procedural services? End quote. Well, all right, you guys, that was just a whopping snippet from the fact sheet that was released by the CMS on July 14th. So really take the time to review into greater detail that fact sheet, as well as the full document of that over 1,500 page PDF file in the proposed rule. There are many, many more codes that are at play. There are supposed to be the brand new ABA CPT codes that are going to be released in January 2027. But again, we need to wait and see if that happens, because this is just the proposed rule. But I'm definitely excited to read deeper into those new potential 6 codes that may be released by CPT. So very, very fascinating. I hope you guys take the time to really dig deep, especially for your various specialties, to see what types of specific codes might be released after the final rule drops. Again, after all of you submit your public comments by September 14th. So anyways, you guys, I wish you all an amazing and very, very happy week ahead. Thank you so much for listening on today's episode. And I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.